All right, well, good morning, everyone, and welcome to the FND Hope U.S. Conference on non-epileptic or functional seizures. I want to thank the organizers for the invitation to speak. I'm very excited to be able to work with and speak to this group. The reason being is that there's been a long history of trying to ally with the patient groups. A lot of times what we'll see is that the physicians and clinicians are in one group and the patients and family members are in another group. And this is a wonderful way actually to bring the two together so that there can be a dialogue and to better understand where individuals and family members with NES are coming from, and also for us to hear and learn from patients and vice versa, and conversely for patients and family members to be able to hear from some of the people who see this clinically all the time. And I want to commend the FND Hope organizers for assembling such a great panel of speakers. These are friends and colleagues from around the country and around the world, actually. So really nice program that you put together. And with that, I'll start off with the question that was assigned to me for discussion. You know, what are psychogenic, non-epileptic, or functional seizures? By way of introduction, I do neurology and psychiatry. I trained in both at Brown University, and then I went on to become the director of neuropsychiatry and behavioral neurology at Rhode Island Hospital in Providence, Rhode Island. And then almost 10 years ago, the Veterans Administration asked me to come over part-time to work with veterans who have seizures also, because of the great number of veterans with seizures. So we were able to bring over some of the work that we've done in the civilian hospitals over to the veteran hospitals. And in doing so, we have a tele-seizures clinic for veterans where I see veterans around the country using telehealth, and I'll present some information from that today. And also I'm on staff faculty at Brown University, where I'm a professor of neurology and psychiatry. And so bringing that experience and that perspective, here are my disclosures. A lot of the work that we've done has been through, we're very appreciative of the funding that we've received from various organizations, through the VA and through the NIH and through foundations and through voluntaries. And that has allowed some of the things that I'll be talking about today to happen. So when I'm speaking with clinicians, we give learning objectives. I think that for individuals and for family members, there should be learning objectives also. So I view myself as a physician as an eternal student. And so hopefully I'll be able to share some things that I've learned with you, and you might come away with a few pearls also. So we'll talk about the definition, and we'll talk about how the definition applies to diagnosis and to comorbidities and to treatments. I'm not going to cover the others in depth because you're going to get some great talks later on about those individual bullets underneath the definition. So I'll just kind of give you an introduction or a sampler, and you'll be hearing from the other speakers in depth on those topics. So let's start out with the definition. As a neurologist and a psychiatrist, I view the brain-mind as two sides to one coin. So I don't divide the two out. I don't think, well, you're either going into psychiatric or psychological treatment, or you're either going, or otherwise you're going into neurologic brain disorder. I view the two as you're just looking at the same thing from a different perspective. So in light of that, one of the ways that I explain to my patients what non-epileptic seizures are is that it's a neurological manifestation of an underlying psychological conflict or stressor. Some of the other work that we're doing with biomarkers Another way to look at it is that non-epileptic seizures are a behavioral expression of a neural network dysfunction. And so those aren't either or, those are both and. And so that'll be kind of a perspective as you're learning and listening over the course of this conference to hear. If you can think brain and mind, if you can think neurology and psychiatry, that might help to conceptualize or contextualize some of the talks that you'll be hearing today for the understanding of what non-epileptic seizures are. Some of the materials that you'll see come from a book that we've co-edited with Dr. Stephen Schachter in Boston. Other people on the list of speakers, they've written numerous articles and books, so you might see some of those. This book is mostly for clinicians, and it's kind of an academic book to help clinicians better care for patients with non-epileptic seizures. And what I'd like to do is to provide some hope for individuals with patients and their families who have non-epileptic seizures. And I'll tell you the 3 reasons why I think that we can share some hope in that regard. One is that in the past, as clinicians, we could not definitively make the diagnosis of functional neurological disorders or psychogenic non-epileptic seizures or even conversion disorder, but now we can, and I'll tell you why. Before, we didn't have a treatment for patients with NES, and now we do. And also, we didn't understand the mechanisms for what was going on in the brain, for the neuropathophysiology with NES, and now we have. So that in and of itself, and that's just in the time span of me having gone through my medical training as a student all the way to present. So in that span of time, we've made some great advances working as a clinician researcher community around the country and around the world. And I'll talk about a little of that, and hopefully that'll give you some hope for what we're talking about. So just by way of introduction, these are prevalent. This is a prevalent condition. Many times people are diagnosed with epilepsy, and about 1% of the US population is diagnosed with epilepsy, but realize that up to 20% actually don't have epilepsy. They have non-epileptic seizures. And you'll hear from Dr. Ben Badis, who'll be talking next about how to make the diagnosis. And when patients are coming to seizure monitoring units, for the busier units, up to half of them actually diagnose non-epileptic seizures. Many times people are seen in neurology clinics. Sometimes neurologists, unfortunately, might not know what to do with what's the next step now that we've made the diagnosis. That's changing now that there's more of a dialogue between neurology and psychiatry. People who come in with what's possibly considered to be status epilepticus actually is non-epileptic status. People with non-epileptic seizures actually, it can affect their ability to have gainful employment. They might be on government assistance, and that's similar to what is seen in epilepsy. Some people think that it's only a certain population who have these, but actually it can be in children, and it can be in adults, it can be in elderly, it can be in men and women. And then what happens is over the course of a patient's lifetime, because of more labs and more tests and more medications and more ER visits, it can create a significant cost for individuals. And that adds up to $100,000 for an individual patient for their lifetime, and also up to $1 billion a year in the US alone. So it's a costly disorder, both physically and fiscally, monetarily, psychologically, socially. And over the course of time, as we've improved diagnostic and treatment techniques, then hopefully that can relieve some of this burden. I mentioned earlier we couldn't make the diagnosis before, but now we can. This is one of the reasons why. Is because the manual that psychiatrists and psychologists and physicians use for making diagnoses is called the Diagnostics and Statistics Manual, DSM, and the 5th version, DSM-5, came out in 2013. Some of us were on the panels, the advisory boards, to help change some of the diagnostic criteria. In the prior version, DSM-4, it didn't allow clinicians to make the diagnosis. And the reason why is because there was a statement, one of the criterion was that a relevant psychological stressor had to be found. And what our argument is that, you know what, number one, not everybody had a relevant psychological stressor, and I'll talk a little bit about that, but also not everybody who had a relevant psychological stressor or life event in the past would necessarily share that the first time that they meet a stranger. And so I know for some of my patients, over the course of 5 or 6 appointments, that's where some people have felt comfortable enough to say, you know, doctor, there is this thing that I wanted to tell you. But they needed that assurance that they could trust. And so we realized that that's an important point, but we moved it down to a note instead of a diagnostic criteria. The other thing that we did is we used physical signs on the neurological exam to show that there might be a mismatch between the neuroanatomy and the actual physical presentation. So now that we've got these diagnostic signs that are consistent across functional neurological disorders and conversion disorder, we can actually use that on the exam to help rule in the diagnosis instead of just scratching our head saying, well, I wonder if they have it, I'm not sure. So that's one of the reasons for Hope, is that we can definitively make a diagnosis of functional seizures and conversion disorder and psychogenic non-epileptic seizures. Some people will say, well, we're concerned that they might be faking or lying. And unfortunately, some of you as patients and family members might have heard that. I hate that that's the case, because I know that there's a small percentage of people who are trying to, get out of something and they're using that, but that's a very minute population. The majority of patients I see, those are people who are struggling with this unconscious process that they may or may not be aware of, and these manifestations of physical symptoms, and they're not malingering and they're not faking. That's why we don't use the term pseudo seizures anymore. You might have heard that in the past. Pseudo means false or fake. And I tell my patients, these aren't fake seizures. They're not false seizures. They're real seizures. They're just not caused by abnormal brain cell firing. And so that's one of the reasons why you'll hear in future talks about terminology. We don't use the term pseudo seizures anymore. We use the term non-epileptic seizures or functional seizures, as you've heard. When I talked about earlier, we could make the definite diagnosis. Some of the work that we've done with collaborators and people who will be speaking is that there's a high level of reliability between readers of EEGs when we have video EEGs, when we have a history from the patient, a video of the seizure, and also a video EEG an EEG that corresponds with that seizure. That gives us a really high level of diagnostic certainty. So if you haven't had a video EEG and you're wondering about your diagnosis, then I would say encourage your clinician. Hey, we've tried 3 anti-seizure medications and it's not working. Maybe we should be looking for something else. And just because you have one type of seizure doesn't mean it has to be epilepsy. So when people say generalized tonic-clonic seizure or grand mal seizure, a lot of times they're thinking, well, that's synonymous with epilepsy. Any way that an epileptic seizure can present, a non-epileptic seizure can present. So that's important to note when you're getting somebody to give a description, and when you're giving a description to your doctor about your seizures, and you might not just have one type, you may have a couple of types. Make sure to give a clear definition and description from start to finish of the various types of seizures you have. Another thing that people confuse sometimes is that, well, I had a traumatic brain injury. I had a TBI, so it must be epilepsy. Not necessarily. In our studies, we found that almost half of people with non-epileptic seizures have had a TBI. The TBI type, though, is it's a mild TBI in about 3/4 of those patients. So just because you had a head injury doesn't mean it's epilepsy. Again, being able to describe the history clearly and with good time points, and even with old medical records, that's going to help your clinicians take better care. The other thing we talk about with diagnosis is that there are what's called comorbidities or co-occurring illnesses. And in this case, the majority of patients, not everybody, but the majority of patients with non-epileptic seizures have some comorbidity. Now, that may not be all-out major depressive disorder or post-traumatic stress disorder as listed here, which half of people can have. There may be what's called subthreshold symptoms, which means some anxiety or some depression. And it's important to pay attention not just to the seizure, but also to the comorbidities. And that's one of the important things for treatment approaches that we'll talk about. So diagnosis informs treatment, and acknowledging, you know what, I've got some anxiety that I want to deal with, or I've got some things that have happened in the past that'll help me to take better care, not only of myself, but of the seizures also. Also realize that this doesn't just affect the individual, it affects the family, because we exist in community. And in that regard, communication between family members or issues that are going on with family can interact with an individual's seizure patterns. So having that discussion, not just as an individual, but also in the context of your support system or your family system, is really important. About 10% of people have mixed epilepsy and non-epileptic seizures. So that's why I said earlier, it's important not just to talk about your seizure, but about your seizures if you have more than one type, and give a good description of those. We can find out in the monitoring units whether or not those are both epileptic, both non-epileptic, or epileptic and non-epileptic seizures, and that's going to inform treatment also. One way that you can help your clinicians, some people can't get into the monitoring unit. I tell people, use your smartphone and take video and show your clinician from start to finish, not just in the middle of the seizure, but at the very beginning. When you start to have that warning, it's happening, and either video yourself or have a family member video you and give that video to your clinician. Some of the work that we've done with our collaborators has shown that smartphones can help with diagnosis. Another reason for hope for patients and clinicians is that the National Institute of Neurological Disorders and Stroke, the NINDS, actually is interested in this. And as you know, the NIH is the largest funder of clinical research and biomedical research in the world, and it's on their radar. So you can speak up as advocates when you talk to your congressman and when you talk to the NIH, and you can put in, you can lobby for, we need more research in FND, and we need more research in conversion disorders and functional neurological disorders, because it's a prevalent condition and we still can learn more about it to help more people. So hopefully that'll help to encourage you to speak up. When I talked about earlier being in the seizure monitoring unit, that's going to be the gold standard. And then we can use that information for documented non-epileptic seizures. If you don't have the video EEG, we can still make the diagnosis, but it's with less diagnostic certainty. So you can have established or possible or probable. Ultimately, you want to have documented seizures on video EEG. I tell people that the treatment team is part of the clinicians are part of the treatment team, but we really want to encourage a patient-centered, patient-focused treatment. And so what that incorporates is not just that you're going to see the doctor or the psychologist, it's also you're going to see you're also going to incorporate the elements in your community that are very important. So I tell people family, friends, faith, those are all part of your treatment team, if you will, your support community. So make sure to have that discussion with other people about, hey, these are my seizures. We've got a diagnosis. I'm seeing psychologists and psychiatrists and neurologists and social work. We've got a bunch of people that we're working with, but you're part of that team also. So now hopefully giving you some hope for diagnosis. Now we can give you some hope for treatments. We've been working over 20 years now to try and develop treatments for patients with non-epileptic seizures. And we have looked at medications. We've looked at psychotherapies. We're looking at biomarkers. I'll give you a little taste of that. Again, I'm not going to go in depth because you've got other people who are going to be talking about these more in depth throughout this conference. But I'll say initially, when I started this, after my residency, there were no randomized controlled trials. And that's kind of the gold standard for treatments. Over the course of time, we had expert opinion, and that's valuable, but it's not the highest level of evidence. And so over the course of time, we've tried to look at medications. We did find that certain medications, what are called SSRIs or antidepressants, those actually can reduce some of the seizures, but it doesn't make them go away completely. So if you talk to your doctors about, well, can you prescribe this medication? Anti-epileptic drugs, anti-seizure medications do not treat non-epileptic seizures. And also the drugs for depression and anxiety, they can help some of the comorbid symptoms that I talked about earlier, but they're not necessarily going to make the seizures go away completely. So then we looked at what we dubbed as cognitive behavioral therapy. I'll tell you in a minute why it's not CBT, but that's a buzzword that people use. There are some studies out there that do use conventional CBT, but that's not what this is. So when we did our initial trials in the early 2000s, we found a significant reduction in seizures in patients who received this treatment. And this is the model that we use for that treatment. So many times, a person has had some type of an issue in the past, either an injury or a trauma. It could be remotely from younger, or it could be recently, or it could be something that happened in the past that was reactivated with something that happened again. It could be a loss. It doesn't have to be that somebody was abused. That's not what I'm saying. What I'm saying is that there could be a life event that occurred, and we've all got life events. So something could have happened, and then they develop a non-epileptic seizure or a psychogenic movement disorder, a functional tremor, or a weakness. Then what happens is life is a catastrophe. Everything has been taken away from me. And then there's this fear of the next seizure. I don't know when it's going to happen again. And then people stop going outside anymore and they avoid external environments. And then they start to pay attention to what's going on inside. It's what we call hypervigilance. What was that sensation I just had? Could this be something else? And then there's this cycle of disuse and disability and depression. And that vicious cycle spins in many of our patients' lives. So what we'll do with the treatment is we'll equip them with tools to help to see that cycle and to make those links. Then they use the tools to break those links. And so it's really empowering the individual to kind of manage their own care. I tell my patients, I'm trying to work myself out of a job. I don't want you to have to come back and see me. I want you to go out and live your life. And so when people get the various treatments, then they really have the ability to do self-management. They become self-effective, and they can live their lives. So that's the vicious cycle that when they use the tools, they're able to confront their fears and they move into recovery. Now, there's no treatment that is 100%. Anybody who speaks on any treatment, medical or psychological, nobody has a 100% cure rate. I wish we did, but we don't. But we subjected our treatment to a multi-site trial with a few different sites. And what we found is that the 2 therapy-containing arms actually had a reduction in seizures and in symptoms and improvement in quality of life and function. Now, again, that doesn't mean everybody becomes seizure-free. It means that there was a significant reduction in seizures. That was in contrast to the patients who received the antidepressant medication. They had a reduction in depression and a trend in seizure reduction. And then the 4th arm was standard medical care. Now, that's what's done at all of the epilepsy centers. And what we found was that there's no significant reduction in seizures or secondary outcomes. So that made us think, you know what? What's used as status quo is not sufficient. And so we need to make sure to equip clinicians to be able to help people around the country, maybe and around the world, with their seizures and their comorbidities. And this is the reduction in seizures that you see in the 2 therapy-containing arm and non-significant in the treatment as usual arm. We call this therapy neurobehavioral therapy because it was initially called neurobehavioral approach, and it was used initially for epilepsy, interestingly, not for non-epileptic seizures. And Ryder and Andrews out in California used this as a behavioral intervention for epilepsy by helping people to identify their aura and then to use some behavioral techniques to reduce the progression of their epileptic seizure. So we asked for permission to modify it. And with the success in some of the treatment trials, Oxford University Press asked us to publish this as Taking Control of Your Seizures. The workbook is for the patient to use with a clinician. And then for the clinicians, there's a therapist guide, which can help them to understand some of the nuances of treating patients with seizures, whether it's epileptic or non-epileptic. And these are the treatment sessions. It's 12 sessions. It's not a lifetime of therapy. It's 12 individual 1-hour weekly sessions that the patient does the workbook, and then they go in and they discuss the work that they've done with their therapist, with their seizure therapist, seizure counselor. So each of the therapy sessions has a different type of psychotherapy, and that's why we don't call this CBT, is because there are different, what we call modalities, or different types of therapy mixed throughout this treatment. We've trained people around the country in the VAs to help veterans with seizures, and we've also done the same in civilian hospitals, training doctors. Now this is neurologists, psychiatrists, psychologists, epileptologists, social workers, psychiatric nurses. People around the country have been trained in that way. They can possibly help people using this or other interventions. The intervention I talked about is just one. You'll hear about a number of other interventions. People, there are experts around the country and around the world who have different approaches. And so that's why I say that this is one of many opportunities for treatment. It can also be delivered via telehealth. I've had a telehealth clinic since 2012, and even earlier in that in the research, but we were able to publish to show that, you know what, whether you come in clinic or whether you're seen via telehealth, there's a similar reduction in seizures over time using the treatment. I mentioned also that this is not just about the individual, it's about the family. Some of the people that'll be talking, you'll hear, they're actually family therapy programs that help patients with seizures. And so that might be another thing to consider when you're thinking about treatment, is not just what do I need to do, but our family system. How can we maximize the health of that also? So I'll close with that third piece of hope that I talked about. One was diagnosis, two was treatment, and third is we're better understanding some of the neuropathophysiology. One of the ways that we're doing that is we're looking at brain connections or neural networks. And in a study that we have right now with partners at University of Alabama at Birmingham, it's a DoD-funded study where patients between ages of 18 to 60 who have diagnosis of non-epileptic seizures with a history of epilepsy, with a history of traumatic brain injury, or the other group is a history of epileptic seizures with a history of TBI. You can't have both, you can have either. They're getting an fMRI either in Providence or in Birmingham, and then we're giving them the 12 sessions of the treatment that can be delivered remotely. And then we're getting another fMRI after that treatment to look for brain network changes. And so we're understanding brain networks better now as we progress with the science. So with that, I'll bring it to a close saying it's important to treat the whole patient. And so if you hear your doctors talking only about a biological perspective, let them know that there's also biological, psychological, social, and spiritual elements that are also part of the whole person. So you can I'm encouraging you to speak up to your doctors to say, do you use a biopsychosocial spiritual perspective in your treatment? Because I want to make sure that the whole person is being cared for here. And the reason why I incorporate that fourth element is because you as patients and family members don't just bring up, I have a headache. There are also existential concerns. I'm concerned about life. I'm concerned about the impact on, who I am as a person. And so that's where I say this model that we use, the BPSS model, is one where we can actually look to the whole person as a human being. So in closing, I'd just like to say that many times people talk about, well, what is, non-epileptic seizures? The way that I try and simplify it for myself, and what I've learned over the decades of seeing thousands of patients, is that in many ways, this is a disorder of communication. What I mean by that is we express distress one way or another. And if we don't learn how to express distress in a healthy verbal manner, it's going to come out in another way, sometimes with physical symptoms. So part of the treatment that we help teach people is, if you can use healthy assertive communication and say, I'm upset about this, or I'm angry about this, or this hurts me, those type of things, that's where I see a reduction in physical symptoms as people are able to express distress in a healthy way. So to wrap up, one way to conceptualize this is get the proper diagnosis. Make sure you understand your diagnosis, not just you, but your family. Create a problem list of things that have happened before, things that are happening now, things that are affected in the future. That's called predisposing, precipitating, and perpetuating factors. And then you may need medications, a change of medications, an addition of medications, using psychotherapies. That's where you can put all of this together for a good treatment plan. There are some information sheets available from the American Epilepsy Society that you can use. And then in conclusion, I'll just say that you have reason for hope. The reason why is because we can make the diagnosis now. We have some treatments that are available. You'll hear more about that also. And then lastly, we're better understanding about the comorbidities and about the neurology and the neuropathophysiology of these disorders. The research that we've done has been with excellent collaborators and friends around the country and around the world. And if you are interested in being screened for the current DoD study that we have, feel free to contact our research coordinator. And you can email ktaco@lifespan.org, and she can screen to see if that's something that you may be interested and eligible for. And with that, I will close.
All right, Dr. LaFrance, thank you so much. We really appreciate you taking the time to speak with us.